Hello, and thank you for joining us for this MD Magazine peer exchange entitled Precision Medicine in the Treatment of Severe Asthma. A greater understanding of the molecular pathways associated with asthma has led to new therapeutic strategies, and that requires a more individualized approach. This MD Magazine peer exchange panel of experts is going to provide an overview of recent advances, and it's going to discuss best practices in patient assessment and treatment, with a focus on the role for newer biologic therapies in the overall management of severe disease. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons. I'm associate director of surgical intensive care at the New York Presbyterian Hospital in New York City. Joining me for this discussion are Dr. Neil Jain, Director of Research for Arizona Allergy and Immunology Research and co-owner of Santan Allergy and Asthma in Gilbert, Arizona. Dr. David Rosenstreich, Director of the Division of Allergy and Immunology at the Albert Einstein College of Medicine, Montefiore Medical Center, right here in New York. And Dr. Rafi Tashian, Assistant Professor of Medicine and Pediatrics at the David Geffen School of Medicine at UCLA in Los Angeles, California. Thank you all for joining us. Let's get to work, shall we? Asthma is a tricky disease. When I was in medical school, asthma was asthma, but nothing stays that way forever. And it looks like now it's pretty heterogeneous. So why don't we start with the real easy stuff, maybe? How do you define asthma?
Yeah, so I think the classic textbook definition would be that it's a chronic disease of the airways, typically manifest by airway inflammation, whereby there is at least some reversible airflow obstruction.
Now that's a clinical definition, right?
Absolutely.
Actually, it's more of a lab definition, the more I think about
Yeah.
it. From the clinician's perspective, if someone comes in wheezing, that person's thinking what? Asthma.
Right.
Is that so far from right?
Well, you can also look at the cardinal signs and go textbook with it, with wheezing, chest tightness, shortness of breath, or cough. But in essence, part of it is your gut feeling of how often is this getting in the way of life and the impact on the person's health.
One of the things I noticed over the years is that a lot of asthmatics present more with a cough than with a wheeze. Why is that?
Yeah, I think one of the challenges in asthma, alluding to sort of what you were just mentioning, is that asthma can be variable. And people will have coughing, they'll have wheezing, they'll have shortness of breath, and those symptoms can occur at various times, sometimes with activity, sometimes without. And because there are other conditions that can manifest similarly, it makes it a challenge. People will come in with wheeze for a variety of reasons. They'll come in with cough for a variety of reasons. And trying to know, is this asthma or is this not asthma? I think that's the challenge that we're all faced with.
Now, the other thing I hear all the time is expiratory airflow limitation. Why couldn't inspiratory airflow limitation be asthma as well? Or can it?
Well, it's airway obstruction.
Okay.
The airways are narrowed. It's easier to breathe in than it is to breathe out. So you pick it up more on the breathing out. The patients actually don't perceive that. They rarely perceive whether it's in or out. They just feel their chest is tight. That's primarily what they come in with. It's, I think, the leading symptom they feel. They just feel discomfort. They feel that their chest is tight. They know they're just not getting enough air. And that's how they show up.
I think from an inspiratory, expiratory standpoint, typically, what we're taught, obviously, in med school is that inspiratory airflow obstruction is something that's related to your upper airway, right? And that just has to do with the dynamics and the physiology of our airways. Whereas lower airway obstruction is going to manifest as expiratory difficulty.
If you think about the pressure relationships in the thorax and the upper airway, right?
Right.
If you increase the volume, you will dilate your airways
Absolutely.
below the glottis.
Right.
That makes it easier.
Right.
And then if you try to breathe in with an obstruction above the glottis, it's going to flap shut.